XLH, but we have effective treatment, and there's more effective treatments that are coming along every day. And of course, it's inherited. So Becky mentioned about how common XLH is. One of the diseases that kidney specialists see is polycystic kidney disease, and you can see that the dominant form can be seen in 1 in 1,000, so that's relatively common. Cystic fibrosis and diabetes, 1 in 4,000. XLH, 1 in 20,000. So in the Bay Area, which has a population of about 800,000, that's 40 patients with XLH. And the more rare diseases, such as Fabry disease or primary hyperoxaluria, are 5 times less common than XLH. So we do have a genetics counselor as a speaker, and I don't want to say what I imagine she's going to say, but I did plan to spend a few slides on the inheritance. And so we know that XLH is a so-called X-linked dominant disease, and that means that the abnormal or faulty gene is on the X chromosome. And so males who have 1 X chromosome and 1 Y chromosome are always affected, and females who have 2 X's are affected as well, although the severity can be different. There can be a variable severity in females. And so how is XLH passed on? So let's imagine that the father has the disease. So if the father has a daughter, the daughter will get the abnormal X chromosome from the dad, and so all daughters will have XLH. And none of his sons will have XLH. If mother has the disease, then it's pretty much a 50-50 chance that either the daughters or the sons will be affected. There's no way to predict that. So what happens when you have XLH? If you inherit the abnormal gene from a father or a mother, what does that look like? And most of you are familiar with this. Children with XLH do not grow normally. They have deformities in the legs that show up usually very early in life, and you can see up here, this pointer doesn't show very well, but you can see in the top right, the legs are bowed, the knees turn out. You can see deformity at the lower leg. It's a little bit more severe on the left side of the slide. What you can't see here are the abnormalities that occur at the hips, and so children walk with a very wide-based gait. The X-ray below is from a different child, and you can see how the bones are very abnormally shaped. They're wide at the joints, and they curve. And so these are typical findings in children, and as a result of these abnormalities, children have bone pain. Adults with XLH have bones that don't properly mineralize. We call this osteomalacia, and as a result, fractures can occur. So-called insufficiency fractures are fractures that are sort of at the microscopic level and occur just with normal daily activity. The tendons and ligaments become calcified, usually after the age of 40. This can cause disability, limited range of motion, stiffness, pain, and collectively we call this, and this can also affect the joints, and we call this osteoarthritis, and the teeth can also be affected with abscesses. So XLH is a disease where the phosphorus level in the blood is abnormal, and so I want to spend a few minutes talking about that. So phosphorus is one of the minerals in the body. It's a very important mineral, and it's critical for skeletal growth and development. So The bones contain most of the body's phosphorus and calcium are present in the bone. If you don't have normal levels of phosphorus, growth is impaired. And the cells talk to each other in the course of normal metabolism, and that requires phosphorus to be present in normal amounts. And so you can imagine that because phosphorus is so important, the body has a number of systems to regulate the level in a very precise way. And so this kind of gives an overview of how the body treats phosphorus. And you may not be used to thinking about it in quite this way, but on the left there's a cartoon of the intestine, and so phosphorus comes into the body in the form of diet. An average intake is about 1.5 grams. And 2/3 of the phosphorus that we eat is absorbed and enters the bloodstream. And when we measure the blood level of phosphorus, that's what we're checking, that's what we're measuring. From the blood, phosphorus can go into bone when bone is formed, and it can come out of bone in the sort of a normal turnover process. And the levels, for phosphorus to go into the bone properly in children who are growing and in adults, the levels need to be maintained within a normal range. And the main organ that is responsible for regulating the blood phosphorus level is the kidney. So the kidney has a number of systems that are precisely designed to keep the phosphorus levels in blood in the normal range so that bone growth can proceed at the proper rate. And so when you have XLH, what happens? Well, the kidney does not do its proper job in regulating the blood phosphorus level. The kidney cannot conserve phosphorus normally, and so the level in the blood falls. And it can fall to quite low levels, more than 50% lower than normal, sometimes 2/3 of the normal level. And that's because this little protein, which is in the upper right corner, which is responsible for moving phosphorus through the kidney, is affected. Another important function of the kidney is to make vitamin D. And my advancer is, there we go. So we know that vitamin D is important for bone health, and it turns out that while we get vitamin D when we're exposed to the sun and when we take vitamin D supplements, it turns out that that vitamin D needs to be processed in the body in 2 tissues. One is the liver, and the second is the kidney. So the kidney is really important for making vitamin D that the body uses. And in XLH, production of the active form of vitamin D is blocked. And so the blood levels of vitamin D tend to fall or tend to not be within the normal range. And as a result, we have rickets in children, poorly mineralized bone in the adult, which again we call osteomalacia. And giving vitamin D in sort of the normal amounts is really not sufficient to treat this problem. And so that's why the name was originally called vitamin D resistance. So XLH has been known for more than 50 years. And over the years, we've learned more and more about what actually causes XLH. And I think the story is very interesting, and I'd like to describe it briefly. So the first description of a child with what we now call XLH occurred back in 1937, when at that time rickets was a very common disease. And children could be treated by giving them vitamin D in the form of cod liver oil. And a standard amount of vitamin D would treat rickets and heal rickets in most children. But it turned out that a small number of children were recognized as not responding to this kind of treatment. And these children needed 1,000-fold or 10,000-fold more vitamin D in order for their rickets to be healed. And so this was recognized for the first time in 1937, and so these children were given the name vitamin D resistant rickets. And then in 1958, there was a study in which hundreds of patients from a variety of families were studied, and it was shown that this condition of vitamin D resistance was passed along in what we call an X-linked or a sex-linked manner. And that's the first time that we understood more about how the disease was transmitted. In 1974, it turned out that a man who had XLH developed kidney failure. It wasn't from his XLH per se. He had a kidney disease, but he developed kidney failure and needed a transplant. And so the transplants, that was about maybe 10 to 15 years after kidney transplants were able to be done. And most of the donors at that time were family members. And so this man received a kidney transplant from his sister who was healthy, who did not have XLH. And so most people would think that if the kidney is responsible for XLH and you get a healthy kidney from someone else, like your sister, that XLH should go away. But in fact, it did not go away. The man continued to have low blood phosphorus level and had all the other complications that adults with XLH have. And so this was very curious, and if you read the paper, which was just a very brief sort of two-page report in the medical literature, one of the final conclusions was, because the disease did not go away after kidney transplant, there must be something systemic or humoral about the condition. Okay? So that was the first clue, that it wasn't just the kidney that was responsible for XLH. Next slide. There we go. Well, it turned out that in the mid to late 1970s, scientists who study, who raise mice for a living, and you might think that that's peculiar, but mice were very important in medical research. They recognized that a strain of mice in the laboratory had rickets. They were small, they didn't grow well, and they had deformities of their limbs. And this was just a sort of a spontaneously occurring problem. And when they measured the blood phosphorus levels in these mice, they were very low. When they looked at the vitamin D in these mice, it was also abnormal. And when they studied the inheritance pattern of this condition in the mice, they found that it was X-linked also. So this looked like XLH in mice. And so it turns out that from that day, and because these mice had hypophosphatemia, or low blood phosphorus, they were called the hype mice. And to this day, we use hype mice to learn about XLH. It's a very important animal model of the human condition. And so an experiment was done where a hype mouse and a normal mouse, or so-called wild type, or WT, these two mice were joined together at the hip, if you will. They created kind of like a Siamese mice. And the question was, what would happen to the blood phosphorus levels in the wild type mice? And so here's what happened. Well, the phosphorus levels decreased in the healthy mice that were joined at the hip to the hype mice. And the phosphorus level in the urine increased, and these wild type or healthy mice developed bone abnormalities just like the abnormal mice did. And then they asked, well, is this just because of the surgery and the peculiar nature of the experiment? And so they joined two wild type mice together, and they did not see that problem. The mice continued to be normal after surgery. And so because when you join two mice together, they can exchange factors through the circulation, this was evidence that, again, there was a hormonal basis to XLH. Well, a very interesting experiment was done in 1992 where they actually took kidneys from these hype mice and transplanted them into healthy mice. And they took kidneys from healthy mice and transplanted them into hype mice. So a little bit like the experiment that was done in the man almost 20 years earlier. And so it turns out that if you have normal mice with kidneys from a hype mouse, the blood phosphorus level is completely normal. And if you are a hype mouse and you have kidneys from a healthy mouse, you still have hypophosphatemia. So this was very strong evidence that the disease was due to something in the animal, not in the kidney. A few years, actually the same year, we found out what was responsible for actually regulating phosphate reabsorption in the kidney. The gene was identified, and the gene was on a different chromosome it was not on the X chromosome. So that was, again, put the kidneys in the clear, if you will. So in 1995, by studying hundreds of patients and families, the actual abnormal gene in XLH was identified, and it was called the PHEX gene. It's a catchy name, and here's how it was named. The letters stand for phosphate regulating gene, with H for homologies. Homologies means it's similar to. E for endopeptidase, which is a protein that acts in cells, located on the X chromosome. So that's where the name comes from. That's the abnormal gene. The PHEX protein is in bone, and it's in cartilage, and it's in teeth, but it's not in the kidney. Again, another sort of puzzle at the time. We don't know, it was not known what this enzyme, this PHEX enzyme, acted on, but the theory at the time was that PHEX regulated either the production or the metabolism of a circulating hormone that caused phosphate wasting by the kidney. That was consistent with the human transplantation experiment from the early days and with the experiments in the animals. And so this hormone was called phosphatonin because I guess it tones up or normalizes your phosphorus level. Finally, in 2000, a new gene was discovered. The gene is called FGF23. And this was discovered by studying a large group of patients who had a very similar disease to XLH. They had hypophosphatemia and rickets, but rather than it being an X-linked mode of inheritance, it was what we call autosomal dominant inheritance. So it was the same disease, different inheritance pattern, but it allowed investigators to identify a new gene called FGF23, and the gene was abnormal in these patients. And so when they actually could study the FGF23 in the blood, it's a hormone that circulates in blood. It was very high in these patients, and shortly afterwards, it was shown to be very high in XLH patients. So you can see on the right, there's the values of FGF23 in the blood in patients with X-linked hypophosphatemia. I'm not sure you can see the normal range in this particular slide, but it's just about 100. So all the values up to 2,000 and 4,000 are in patients with XLH. Now it turns out that there's a disease where certain patients have tumors, and the tumors are associated with low blood phosphorus and low vitamin D levels. So it looks like XLH, but it's caused by a tumor. The tumors make this FGF23 hormone. The levels are high in the blood, and if you take the tumor out, the disease goes away. So we knew then at the time that XLH was caused by overproduction of a hormone called FGF23 that circulates in the blood, acts on the kidney, and causes the kidney to excrete too much phosphorus and to not make vitamin D. And so what is this protein or hormone, FGF23? Well, it's a hormone like many other hormones that circulate in the body, but it's made in the bone. sort of an unusual place for a hormone to be made. And it's made in a cell called an osteocyte, which is one of the bone cells that's pictured on the right. Osteocytes are cells that can monitor activity in the bone. And one of the things that they monitor is activity, that is physical activity. So if you're a runner or a gymnast and your bones are more strong than someone who sits in a chair all day, that's because the osteocytes can actually detect this physical activity and talk to the rest of the bone and say, let's be strong. If you're a tennis player and you have a very strong forearm, the bones in that forearm are stronger than in your other arm. That's because the osteocytes can monitor that. The osteocytes also monitor the blood level of phosphorus, and they talk to the kidney. They talk to the kidney by binding to what we call a receptor. It's kind of like a key in a lock. FGF23 is the key. The receptor is the lock on the kidney. And when FGF binds to the kidney's receptors, it sends signals through the kidney. And its primary signal is, let's get rid of phosphorus. Let's not save it. Let's excrete it in the urine. Let's tell the kidney not to make vitamin D. And those are the primary actions. And so in XLH, there's too much FGF23. So the PEX gene, the FEX gene is abnormal. The FEX gene is in bone. It tells the bone to make too much FGF23. We don't really know why that happens because we don't yet understand what's controlling FGF23 production by the bone. But at the present time, we understand that an abnormality of the FEX gene in the bone causes the bone to make more FGF23. That FGF23 acts on the kidney, and it causes the kidney to decrease its conservation of phosphate and to decrease its production of vitamin D. There's excess phosphate that's excreted in the urine, and as a result, the blood level of phosphorus goes down, the blood level of 125 dihydroxyvitamin D, which is the active form of vitamin D, goes down, and children develop rickets, and adults don't mineralize their bone and have a series of abnormalities that we discussed. So this is the current understanding of what happens when you have XLH. And it's important to understand this because of the potential to treat. Right now we treat patients with phosphorus and vitamin D, so we treat kind of the end result of this abnormality. If we could treat earlier on, treat the primary abnormality, which is too much FGF23, then the hope is that the treatment would be much more effective and much safer. So I'm going to talk a little bit about treatment, just in kind of brief terms. So the goals of treatment are to improve growth in children, because growth impairment is a primary abnormality, to allow children to grow with straight legs, to improve mobility, exercise tolerance, general improved quality of life, and also to improve mineralization in adult bones, in so-called improve osteomalacia. The current treatment involves use of two medications. One is phosphate salts, usually potassium phosphate. It's given to replace the phosphate that's lost in the urine. It needs to be given in large amounts, usually multiple times a day, because that's so that one can keep up with the kidney, which is excreting phosphorus throughout the day. The other drug that we use is active vitamin D, or calcitriol, and this is given in large doses as well. And that's to help the phosphate be absorbed and also to overcome the block in the kidney where vitamin D is normally made. And so this treatment in children needs to be given throughout their growing years. So this is for 22 to 24 years. Patients should stay on this treatment. Whether adults should be treated is controversial, and many people feel that they should, because if you look at the bone of an adult with XLH, it's very abnormal. Pretty much 100% of the bones of adults with XLH are poorly mineralized and are abnormal. But because of the side effects of this kind of a treatment, many people feel that the treatment should be individualized. Now, there are a number of risks of this kind of treatment. The most common are the side effects of the phosphate, which causes stomach upset, and it can have a laxative-like effect. There are a number of side effects that relate to the chemistry, the biochemistries in the blood and in the urine. So the parathyroid hormone levels, which help regulate bone metabolism, that can go up and cause problems. Because patients are getting large doses of vitamin D, that can increase calcium levels in the blood and calcium levels in the urine, and that can cause calcium deposition in the kidney. We call this nephrocalcinosis. The X-ray or the picture shows a sonogram of the kidney, which the white spots, little white spots that are around the periphery, are calcium deposits. When you have too much calcium in the kidney in this way, it can cause a decrease in kidney function, and some patients have actually gone on to develop kidney failure because of this treatment complication. And it turns out that the primary problem in XLH is FGF23 levels are too high. And what we've learned recently is that giving vitamin D as a treatment increases the FGF23 levels even further. And so it kind of, it works against you in a way. So again, this is the traditional therapy. It's been a treatment in common use for 30 years. And while it's the best we have had up until recently, it's not a fully effective treatment. Children don't grow normally, and there are side effects. There's a new therapy that's emerging, and the primary goal here is to attack the underlying basis for XLH, and that's to block the action of FGF23 on the kidney. By blocking, and so the treatment that's currently being investigated is a medication, is an antibody, so-called an anti-FGF23 antibody that blocks FGF23 and prevents it from binding to the kidney. And again, it treats the underlying disorder, which is too much FGF23. It has the advantage of it doesn't require administration of medications throughout the day, and we hope that it'll have improved safety. And it's been studied in adults in a small number. There's one publication. It raises the blood phosphorus level, and it's been given for 12 to 14 months, and it as an injection once a month, and it can keep the blood level of phosphorus high throughout the month. So it's a very early review, but it has great potential. Resources, XLH Network, days like today. These are the best resources for families. So we've moved a long way from treating rickets in children by taking them to the tanning salon. We now understand in great detail about the molecular basis of XLH, the genetic basis of XLH, and there are very exciting treatments that are on the horizon, and we hope that this disease ultimately will find a cure. So I thank you for your attention and again for coming today. yes, indeed. Questions? So, fire away. Yes, sir.
Dr. Portale, is it fair on my part to say that spontaneous XLH is on the rise?
Spontaneous XLH. Well, it's certainly true that patients with XLH, when we investigate the family, we don't find a parent with the disease. And so we say that this is a spontaneous mutation or a de novo case. Whether it's on the rise or not, I couldn't say. I think it's very uncommon, at least in my experience, to see patients without affected family members, but it does occur. But I couldn't say that it was on the rise. Why do you ask that? I mean, have you heard otherwise, or?
It's probably just in conversation that I may have misunderstood something that was said.
Yeah.
That everything else started to be the case.
I've not heard anyone make that observation, actually. Yes? Well,
They tracked it 7 generations back on my father's side. That's about 1730.
and they found it.
They found it.
Well, it could be that what we call a spontaneous case, we're referring to an investigation that only goes as far as asking, did you have bowed legs as a child? Sometimes the blood phosphorus level will be actually measured, and maybe it won't be abnormal. But as far as, so, but if the genetics aren't actually studied, it may be missed. Okay, over here, I have some questions.
As far as the new treatment, the FGF23 inhibitor,
Yes.
any clarity on the kind of status of that, of the new, the new treatment, the timing for that, or which companies are driving that kind of thing? Just better insight there.
Well, the studies are ongoing. They're sort of in an early stage. My understanding is that there will be a third study that will be starting in the spring for adults with XLH. It'll be more of an expanded study. The initial studies were a relatively small group of patients. So it's still actively in the research phase. I think there needs to be probably a couple of years of additional research before enough information is gathered before it can actually come on the market. So that's not quite ready for that yet. But it's moving forward, and just this past fall, the studies were extended to children. So currently, children between the ages of 5 and 12 are being studied, and so that research project is even earlier. But so far, it's moving forward successfully, and so we can talk after the meeting a little bit further if you'd like. Yes, there are a couple of questions right behind you. Please.
The primary signal for the FGF23 is to get rid of the phosphorus in the kidneys. What are the other signals that it has,
The other signals that the kidneys have.
that FGF23 does?
Or what else does it do? Well, it blocks vitamin D production by the kidney.
Right.
So those are the two main actions on the kidney. It turns out that, and we think those are the most important actions, but FGF23 actually also acts on the parathyroid gland, and it lowers the parathyroid hormone level. We don't think that that's, well, we don't know whether that's important in XLH or not. It turns out that if you have chronic kidney failure, you have very high FGF23. It's for an entirely different reason than in XLH, but it turns out that the levels of FGF23 in the blood in patients with chronic kidney failure are very, very high, much higher than in XLH. And we think that that has some consequences. It turns out that the heart, that FGF23 can act on the heart in a negative way. It's not a good effect, it's a negative effect. And so that's a problem with too much FGF23 when you have kidney failure. We don't think that that's an important problem in XLH because the levels are lower, but in kidney failure, it clearly is a risk factor for heart disease.
Okay. And I saw that the current 23 was listed as an antibody up there. How does this
Yes.
interact with the autoimmune system?
At the moment, there does not appear to be any interaction with the immune system. They haven't identified any allergic reactions or negative effects on the immune system, at least so far.
Hi, Dr. Portale.
Hello.
I don't know if you remember me. I'm Esther.
Yes,
I
hi.
think I was your patient about 1980 or something like that, 1979.
You're making me feel old.
Sorry. My daughter also saw you a couple times. This is Macy. She's 20. So our main concern is, I pass it on to my daughter. My other daughter does not have XLH. One question is, how do I become part of your study? And my other question is, I was always told that my children will have a less severity of a case. And that's always, it still seems like when I read on the internet what I've been finding, the children will have a less severity of a case than what I had. However, with Macy, that wasn't true. She, her legs seemed to bowed more, and as she reached puberty, it was more profound. She had to have some surgeries, and however, she never had any pain, like in the joints and stuff like that. I had a lot of pain. Mm-hmm. So is that changed?
Well, the severity within families is variable. It's not true that children will have less severe disease than their parents. It may be more severe, it may be less. It's really quite variable, even within the same family. We can talk afterwards about your other question, though. Up here, front, yes.
So, could you say a little bit more about the difference between XLH and ADHR? I think that's what you call it, the autosomal dominant, or...
Right, autosomal dominant hypophosphatemic rickets. Well, there are a lot of similarities. The underlying cause is the same, meaning there's too much FGF23. The reason for that is different. I mean, the X-linked disease, there's a FEX mutation that drives FGF23 high. In ADHR, it's an FGF23 mutation that causes too much of FGF23 to be in the circulation. But the bottom line is FGF23 is too high in both, and it has the same effect on the kidney. In other words, low phosphorus, impaired vitamin D production, and sort of the rachitic disease and the bone disease in adults. There are some differences in how the disease behaves. Some patients with ADHR don't actually develop the disease until they become older. In an XLH, it pretty much starts in childhood. Some people with ADHR seem to actually get better over time. There's less severe hypophosphatemia, and we don't really understand why that's the case. So many similarities, but some clear-cut differences as well.
So is the only way that, like in a given patient, is the genetic test the only way to tell the difference between who's got one or the other?
Well, that's the best way. But let's say if a father has it and the son has it, that can't be XLH, right? So you can tell about the genetics sometimes from the family history. You can see the inheritance pattern.
I see.
Yeah. In the back, yes?
I have a question about, I've been listening to different parents talk about growth hormone, no growth hormone, surgery for the leg, no surgery for the leg. Oh, okay. Is there any data or anything anywhere saying the benefits of any of this, like a resource, for parents? Because everybody, we kind of ask each other, well, does your doctor say you should have surgery? Does your doctor say the growth hormone is beneficial? We're told no, absolutely not for both by our doctor for our son, but other people say, oh yeah, well, we do this or we do that. So is anybody putting any kind of anything together regarding those two specific things?
Well, there's a difference of opinion. Those are controversial areas. There is information on the XLH network, but it doesn't address your specific problem or your specific question. I mean, there's a lot of general information. There's also access to the medical literature. So if you wanted to read, and these are technical papers, but if you wanted to read about what's been done and what's known about specific treatments, that's a way to go. Some people use growth hormone and some people don't. I think surgery really depends on the age at which it might be needed, the degree of deformity, the type of surgery. I think many people will do surgery to correct bowing in young children, but wouldn't surgery involving the growth plate, but wouldn't do what we call osteotomy, which would be to break the bone and to reset it in a straighter way. And most people wouldn't do that until growth actually finishes. But if the bowing or the deformity is very severe, then that might be the best way to treat a given child. So it has to be highly individualized. Okay, thank you again.